David, thinking about the family members, do you screen? Do you look at genetic risk factors for patients?
Yeah, well, I think just one other point about sort of global incidence is that there's a shift globally to more proximal cancers of the G junction and proximal stomach, which are more aggressive, much worse outcome, and potentially a relation between reflux and Barrett's esophagus. But in terms of familial risks, we always have to take a family cancer history, and we now have clearly defined genetic syndromes that put patients at risk for developing gastric cancer, and probably the most significant is hereditary diffuse gastric cancer, or CDH1-related gastric cancer, which, although it's very uncommon, it's an autosomal dominant inheritance, and patients have up to a 75 to 80% risk of developing gastric cancer by age 40 to 50. They're multifocal cancers, so once we identify individuals that have this, we have to screen the family, and we recommend prophylactic gastrectomy. There's not really appropriate screening for these patients because they develop multifocal diffuse gastric cancers. Other relevant syndromes, Lynch syndrome has an associated risk of developing gastric cancer, and Lynch families should undergo periodic screening upper endoscopy. I'm also an advocate in Lynch patients for prophylactic aspirin because I think aspirin therapy may potentially reduce the risk of future cancer development. Even BRCA-related breast cancer has an increased risk of patients developing gastric cancer. We don't routinely recommend screening endoscopy in BRCA families, but occasionally you will see gastric cancers developing in these families, and they probably should consider periodic screening. And then the more esoteric polyposis syndromes like juvenile polyposis, where screening upper endoscopy is considered. So the one exception would be CDH1 hereditary diffuse gastric cancer, where we recommend prophylactic gastrectomy.
Very interesting. I'm going to take you back to the Barrett's that you made the comment on, because I think a lot of people wonder, you get a patient with Barrett's esophagus, what's the risk and what's the screening procedure for these patients?
Yeah, I think there's always been controversy about the appropriate screening. We do screen patients with chronic reflux, and we identify Barrett's in about 1% of the population. And surveillance endoscopies are typically performed every 2 years because we're looking for dysplasia. Now, even low-grade dysplasia is an indication for radiofrequency ablation. High-grade dysplasia is now treated with radiofrequency ablation and endoscopic resection. But on a positive note, even though Barrett's is common, only 1% of patients develop cancer over 10 years of surveillance. So we do recommend identifying Barrett's and putting patients on surveillance, but the actual risk of developing cancer over years of surveillance is relatively low.
That's good news. That's very good news. And Kohei, you mentioned in Japan more of a broad-based screening rather than for people at increased risk. How often is the screening? What age does it start?
So from the government, screening is recommended for patients older than 40.
Older than 40 years.
Yeah, so usual procedure is endoscopy, but still contrast study by X-ray is also used.
And
but more and more patients underwent, more and more person underwent endoscopical screening.
Yeah, it's not like a colonoscopy, yes.
Yeah.
And how often are they getting screened?
Every 2 years, is recommended.
Very good, very good. So now we have a patient that's come in, has gastroesophageal cancer diagnosis. Talk to us, Manish, what's your initial workup? What tests need to be done? What tests could be done? What's your recommendation?
Sure. So for a gastroesophageal cancer, we typically start with both an endoscopy and a CAT scan. So we need tissue. The old adage, tissue is the issue. So tissue is important for making the diagnosis, the subtype of the disease, and for any future molecular testing that we'll need to do. And then a CAT scan is perhaps the most economical and best first step. About half the patients will be diagnosed with more extensive disease, metastatic disease, and for those patients, you don't need any further local testing, like an endoscopic ultrasound or anything like that. But if the CAT scan doesn't show metastatic disease, then often an endoscopic ultrasound might be important to determine the extent of local spread of disease, the depth of invasion, and whether nodal disease is present. that may be important for how we approach the patient initially. And then a PET scan is also important, particularly for esophageal cancer, but even for gastric cancer. It can identify about 10% of occult metastatic disease. This is disease that might be in a lymph node that seems like normal size, or bone mets, or things like that. So that's your typical screening procedure.
So we're hearing so much about locally advanced esophageal cancers versus GE junctional cancers versus gastric cancers. Tell us, when I'm reading that endoscopy report, what am I paying attention to, and how does that help me influence what we're going to do?
Sure. So whereas for metastatic patients, the treatment might be overlapping and very similar, the approach to a patient for localized disease can be very different for esophageal tumors versus gastric tumors. And then GE junction tumors, I think it depends on where's the predominant disease. Is it more esophageal or is it more gastric? Setting aside the pure type 2 GE junction tumors, which could be treated both ways, but people have preferences. So for esophageal, so on an endoscopy report, we try to look for the location of the disease. Often they'll say that there's a mass located certain centimeters from the incisors. Typically the GE junction is around 38 to 42 centimeters from the incisors, so tumors that are more proximal to that, so a shorter distance, would be more esophageal, and more distal would be more gastric. That's not entirely a perfect way to do it because patients are different size. So sometimes the GE junction is higher or lower. If you're lucky, the endoscopy report might say the GE junction is at a certain level, or the Z line is at a certain level. That's where there's a curve that's made in the stomach. But you want to try to find the location. You also, I think, want to find other characteristics that may help you sort of manage a patient later. Is it a partially obstructing lesion? Is it not? Is it cratered? Is there a risk for bleeding? Things like that. Those things might help as well for management.